All right, good morning, everyone. Thank you for joining us today. We are coming to you from the McMaster Health Forum at McMaster University in Hamilton, Ontario, Canada. This is our first Queen Elizabeth Scholarship webinar. We will be doing a series of these for all of our Queen Elizabeth scholars, and Boniface from Uganda is drawing the short straw, and he will be the first one for today. We will be, as I said, a series of these webinars over the next 6 to 8 months. So please keep an eye on our social media platforms for the announcements as they come available. I'm going to do a quick little preamble, talk to you a little bit about the forum and the scholarship program, and then I will turn things over to our guest speaker, Boniface, who will be delivering a talk on the Ugandan Health System. So welcome to everyone. We have people joining us from around the world today. We have Queen Elizabeth scholars in Sydney, Australia, and India, and Trinidad and Tobago who will be joining us, as well as people from Uganda and from Canada from coast to coast. So welcome, everyone. So the first thing we're going to do today is just talk a little bit about the McMaster Health Forum. For those of you who don't know what the forum is and what we do, we are a leading hub for improving health outcomes through collective problem solving. We harness information, convene stakeholders, prepare action-oriented leaders, and we are an agent of change by empowering stakeholders. That is the primary mandate of the McMaster Health Forum. And with that, we have combined with the Queen Elizabeth Scholarship Program to offer a scholarship program in health systems. The Queen Elizabeth Scholarship Program, for those of you who don't know, is run by a partnership between the Rideau Hall Foundation, the Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the scholarship program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing education, discovery, and professional experiences. So that is the main foundation of the actual scholarship program. And here at the McMaster Health Forum, we have a specific Queen Elizabeth Scholarship Program, which is geared towards our mandate, which is health systems. So the Queen Elizabeth Scholarship Program at the Forum is strengthening of health systems, and our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. So our current scholars, we have 10 current scholars through our scholarship program here at the McMaster Health Forum. We have 2 incoming scholars. So Joycelyn, who is here with us today at the forum, is from Ghana, and Boniface is from Uganda, who will be doing his presentation today. We have outgoing scholars. Rhonda is shortly will be traveling to Ghana. She leaves in a week. And Nicola is currently in northern India. And we also have outgoing interns. Faraz will be traveling to England on Monday. And currently in Australia, we have Christopher, Alexandra, and Ben. And currently in Trinidad and Tobago, we have Ina and Dave. And they're all doing wonderful work around the world, focused on, again, health system strengthening. Our speaker today is our incoming scholar, Boniface. He comes for us from Uganda. He's currently in a PhD program here at McMaster in our health policy program. He's also affiliated with his university back home, which is Makerere University in Uganda. He is a monitoring and evaluation specialist, and he's currently working for integrated community-based initiatives as a monitoring and evaluation advisor. And he's previously worked in Injury Control Center at the Child Health Development Center, the Makerere University, and other organizations. So what I'm going to do now is I'm going to turn it over to our guest speaker, Boniface, who is going to give you an overview of the Ugandan health system. And we will open it up for questions at the end. And I will ask that you please use the chat window to ask any questions throughout the presentation, and we will get to them at the end of the presentation. So Boniface, turning it over to you.
Thank you, James. And good morning, everyone. Yeah, as you have heard from James, I'm Boniface. I'm a PhD research fellow at Makerere University, Uganda. And my research interests are focused on evaluating knowledge translation platforms. Through my PhD studies, I'd be evaluating the Uganda Clearinghouse for Health Policy and Systems Research. It's an online resource that aims at increasing access to evidence for policy making. I'm currently at McMaster University as an incoming scholar supported by Queen Elizabeth Scholarship. Today I'll be making a presentation about the Uganda Health System. My presentation will be structured as follows. I'll give a brief background about Uganda for some of you have never been to Uganda to get an impression of how Uganda looks like, and probably would come and visit Uganda in the future. Then I'll talk about the Uganda Health System, how it is organized, how health services are delivered, its health workforce, and the health financing system. Some little short background about Uganda. Uganda is located on the African continent, and specifically it is in the East Africa. It borders with Kenya in the east, Democratic Republic of Congo in the west, Tanzania in the south, Southern Sudan in the north, and Rwanda in the southwest. And it belongs to the East African community. That is the capital of Uganda. That's the skyline of Kampala. I think this picture was taken recently, so this is how actually Kampala looks like. It's an upcoming city. I wanted also to give you an impression of how the up-country side of Uganda looks like. That is the villages in southwestern Uganda. And so they are beautiful villages, and they are welcome to come and visit such beautiful land. I'll begin by making a comparison of Uganda with her neighbors in East Africa, and I'll basically look at compare Uganda with three of them. I'll compare Uganda with Kenya, Tanzania, and Rwanda. I'll be looking at some of the key statistics. I'll begin with the total population. When you look at the total population, Uganda is actually third in terms of total population in East Africa with 37 million people. It follows Kenya, which has at least 45 million people. Then Tanzania has the highest number of people, is 51 million people. And then the list is Rwanda with 12 million people. Rwanda happens to have the youngest population in East Africa with at most 50% of its population aged 15.6 years. I think it is followed by Tanzania with 17.5 years, then Rwanda at 18.8 years, and lastly, Kenya at 19.3 years. In East Africa, Uganda seems to have a population that has a high growth rate at 3.24, which I think is followed by Rwanda 2.56, then Tanzania, followed by Tanzania 2.79, then Rwanda 2.56, and lastly Kenya. So probably I will explain to you shortly why there is this population growth rate. And we see that Uganda is number 3 in terms of the birth rate. Probably that explains why we have a high population growth. Actually, number 3 in the whole world, just after Niger and Mali. So the birth rate in Uganda is 43.79. And it is followed by Tanzania in East Africa, which is number 17 in the whole world at 36.39. Then by Rwanda at 33.75, which is number 30th in the whole world. Then lastly, Kenya at 26.4, which is 46 in the whole world. Then in terms of maternal mortality ratio, that is the number of women dying from pregnancy-related causes in 100. Uganda seems to be number 3rd after Kenya and Tanzania, with 343. Kenya has 510. Tanzania has 398. And Rwanda has the lowest at 290. Then when we look at infant mortality rate, that is the number of children who die who are under 1 year in every 1,000 live births. Uganda is only better than Rwanda at 45. Then Kenya is at 39.4, Tanzania is at 42.4, and then Rwanda is the worst with 58.2. In terms of life expectancy at birth, in Uganda, it is 54.9. So it means when you live beyond 54.9, you're actually living in some borrowed time. So, and I think it's Uganda with the lowest life expectancy rate in East Africa, followed by Tanzania, rather by Rwanda at 59.7, Tanzania at 61.7. Then Kenya seems to have a better life expectancy than any of its neighbors in East Africa at 63.8. Then in terms of house budget, that is percentage of the gross domestic product, Uganda is 9.8, Kenya is 4.5, Tanzania 7.3, and Rwanda 11.1. I picked on HIV prevalence because HIV happens to be one of the biggest problems in East Africa. The current HIV prevalence in Uganda is at 7.3, which means in every 100 persons in Uganda, you have at least 7 people infected with HIV. And actually, this is a much better prevalence compared to the previous years, especially in the 1990s, where the HIV prevalence was quite high. I think it was 8%. That means in every 100 people, you have 18 people infected with HIV. So, but of course, Uganda in East Africa has the highest prevalence rate, as you can see from the statistics. It is followed by Tanzania at 5.34, Kenya at 5.3, and then Rwanda has the least at 2.82. So that's a comparison how Uganda stands with its neighbors. And it gives us a picture about the whole health system. I'll attempt to use the WHO health system framework to try and explain the Uganda health system. The WHO health system framework has about 6 building blocks: governance, healthcare financing, health workforce, medical products, technologies, information and research, service delivery that all aim at improved health, responsiveness, financial risk protection, and improved efficiency. So I'll try to use the framework to try and explain to you the Uganda health system. The Uganda health system, just like any other system in the world, aims to achieve, promote, and sustain good health for its people. And the Uganda health system has been evolving, I think, for the last 3 to 4 decades to handle the emerging concerns and challenges to the health situations in Uganda, although we still have serious challenges, as we have seen, for example, from the HIV prevalence. Basically, healthcare delivery is done through a decentralized framework, as I'm going to show shortly. This is how the Uganda health system is structured. On top, we have a Minister of Health, which is responsible for policy formulation, resource mobilization, budgeting, and strategic planning. It regulates the health service delivery throughout the whole health system, provides overall stewardship, sets standards, supervises, and monitors the whole health system. Then under the Ministry of Health, we have the national referral hospitals. Currently in Uganda, we have 2 national referral hospitals. Actually, one of them is the biggest hospital in Uganda, which is also a teaching hospital for Makerere University College of Health Science, where I happen to be attached. Yeah, so the national referral hospitals, they offer services in most medical and surgical subspecialties, and this is where actually we have the best doctors in the country specializing in different fields. However, you find that most of these doctors actually operate private clinics because the salaries from the government are not enough, so they want to earn more income, but also contribute to service delivery. Then below the national referral hospitals, we have the regional referral hospitals. So these regional referral hospitals, I think currently we have 12 regional referral hospitals, and they all have specialized clinics with consultants specializing in different fields. They offer services that are offered at those lower level health facilities, like the district facility hospitals, health center 3s, and health center 2s. So when we go down, we see at the district level, we have the district health services. So the district health services take up the roles of the Minister of Health, for example, supervising the health system within the district. You know, I mentioned earlier that it was a decentralized framework. So at the district, we have some autonomous body that oversees the health services in the district. I think at this point, I think it's important to try and explain how the system is organized in Uganda in terms of the political administrative units. So from the national level, we have regions, and within each region, we have districts. So within each district, we have what we call counties, and after counties, we have sub-counties. And so after sub-counties, we have parishes, and lastly, we have villages. So to give an impression of how these look like, a village, I think, has should be having 50 to 70 households, and you find in each sub-county we have like 10, in each parish we have like 10 villages, and then in each sub-county we have at least also 10 parishes. And you will notice that the health system is also organized according to the different political administrative units. So I had reached at the district referral facilities. So in each district, like I've explained, we have a district hospital. And this district hospital is supposed to oversee and supervise the lower health facilities. And so at the sub-county level, we have health center 3s. And remember I said in the sub-county we have like 10 parishes, and in each parish we have like 10 villages, where each village has 40 to 70 households. So these health center 3s are found at the sub-county level, and they are usually headed by a clinical officer. A clinical officer in Uganda standards, I think, has a diploma in clinical and community medicine. And health center 3s are supposed to be having a functioning laboratory. Some are accredited at clinics. Remember I told you the HIV prevalence is high in Uganda. So at the parish level, we have health center 2s at this level. And health center 2s, they are supposed to treat common diseases like malaria. Malaria, I know in Canada, malaria is not common, but in Africa, malaria is common. So at these health center tools, they can manage such conditions. And usually the health center too is headed by an enrolled nurse working with a midwife. And it runs an outpatient clinic for common conditions like I mentioned malaria, and then offers antenatal care to pregnant women. Then last, we have village health teams. This is like the lowest health unit. Actually, is also referred to as Health Center 1, where we have lay people, and basically these lay people are supposed to promote health, generate demand for health services and products, and they get training from the higher health facilities and from non-government organizations in doing their work. So this is how the whole health system in Uganda is organized. Let me begin by talking about the health service delivery. Health service delivery in Uganda is basically through modern and traditional practices. So you see we have modern medicine and still we have traditional practices. And basically in modern practices, we have the public sector at the forefront of providing health services. Then we have private not-for-profit, and basically these are faith-based organizations. Then we have private medical practices. Remember I told you that most of the doctors at national referral hospitals and regional referral hospitals tend to run their private clinics. So we also have private medical practice. But also, remember I told you the last unit in the organization of the Uganda Health System are village health teams. So before I talk about a traditional practice, let me jump to E. We have the community health workers, promoters, or drug peddlers. These are what I already mentioned earlier, that they do community mobilization for health services, promotion for health services, and they also distribute health products like insecticide-treated nets. For your information, insecticide-treated nets, they help to prevent people from being bitten by mosquitoes. So in a way, they help prevent malaria. So back to the health system, the health service delivery is also through traditional practices. And then we have herbal medicine, we have traditional birth attendants, who actually, by the way, also find themselves under E, under community health workers. Because we notice many people are still delivering from home, so we needed them to deliver under some skilled labor. And then we thought traditional birth attendants could receive some training and then they continue attending to these mothers delivering. Then we have bone setters and spiritual leaders, and these spiritual leaders include pastors as well, because you know, healing of somebody is not necessarily the medicine, but also some psychological aspect needs to be touched. When we look at the health workforce, we find in Uganda, according to the recent statistics, I think that is 2015, the public sector contributes about 52%. Then private not-for-profit, basically the faith-based organizations, they contribute 12%. And others, including the private providers, they contribute 36% of the health workforce. However, we still have challenges with staffing levels, especially in public health facilities. You could refer back to the other structure. At national referral hospitals, our staffing levels currently stand at 64%. So that means we have a gap of 36%. At regional referral hospitals, it currently stands at 79%, better than at the national referral hospitals. And at the district facilities, it stands at 69%. And this perhaps explains the gap we have in the ratio of health workers to patients in Uganda, where you have one doctor to 24,000 patients, one nurse to 11,000 patients, one dentist to 77,000 patients, and one laboratory technologist to 16,000 patients. I think that gives a picture about our health workforce. Then let me talk about the health information system. Ministry of Health has a fully-fledged resource center that implements health information management system. So this system is basically for production, analysis, and dissemination of timely information on health determinants, health systems performance, and health status. So this data that feeds into this system is actually captured from the community and then from the health facilities. If you refer back to the structure that describes the organization of our health system. But also, I think it's better also talk about how research is being used to inform policies here. Of course, we still have challenges of having research or evidence really informing policies in Uganda. Recently, there have been efforts to try and bridge the no-do gap in Uganda. And the Makerere University, through a number of projects, of course, with collaboration, in collaboration with McMaster, they have been at the forefront of trying to increase the use of evidence in policy making. And it's for this reason that I'm here, also trying to evaluate one of the online resources to see how to increase the use of evidence in policy making. Then, lastly, I will talk about health financing system. The government of Uganda has steadily increased its budget allocation to the health sector. However, the allocation is still less than 10% of its budget to healthcare, which is actually less than 15% as agreed in the Abuja Declaration by the heads of African states. So I think it was in April 2001 when the heads of states from Africa sat in Abuja. Abuja is found in Nigeria, in West Africa. So they sat in 2001 in April, and then they all agreed that they should allocate 15% of their budgets to health. But I think over years this has not happened. As you can see in Uganda, we still allocate less than that. We allocate 10% of our annual budget to the health sector. The current funding of US dollars 27 per capita per annum expenditure on health is far below what is recommended by WHO of US dollars 44. And of course, most of donor aid is not harmonized and is not always well aligned to a sector plan, and is always managed off of the budget. So you find donors get money and give the money to non-government organizations, and you find most times some of the activities are not captured in the national budget. So probably there is a need to harmonize. Then there is still private out-of-pocket expenditure on health, which is still very high. Uganda at the moment does not have a polling mechanism, but of course there is a proposal going on of having a national insurance scheme. I thank you so much, and I welcome questions. Thank you.
So thank you very much, Boniface. We will open up the room and the chat box online for questions. So while people are thinking about it, I'll ask a question if that's all right with you, Boniface. Okay. So the one thing that struck me when you're looking at the stats was the age of the Ugandan population. 15.6 median age is pretty young. So here in Canada, our healthcare system, we've been dealing with an older population. So in the last 10 years, we've seen lots of changes in our system to help those older populations. So gearing finances and resources away from like long-term care facilities to encourage people to stay at home longer. Home care issues have been a big thing. Self-management care has been, and those types of things. And we've seen a change in our system in the last 10 years to cater to that, health need. So in Uganda, in the last 10 years, has there been any kind of changes or shifts in the way the system's been organized or structured to assist in the needs of what would be a much younger population?
Thank you, James. Yeah, of course, when you move around in Canada, you notice by just eyeballing, you don't need to look at statistics. You notice you have an elderly population. Yeah, in Uganda, there have been some shift of trying to have youth-friendly services. And actually, in most of these health facilities, if I can go back to that structure, you'll find that Health Center 3, and especially the district-based hospitals, they have tried to create youth-friendly corners. Because they appreciate, we appreciate that, the youth is a tricky group. They wouldn't want to come and seek for services together with the general population. They are a little bit shy. So you need to create their unique corners where they freely come and get services. For example, the youth is highly affected by HIV in Uganda. And so one way has been to promote what we call ABC. ABC is abstinence, be faithful, and use condom when you cannot. And so the use of condom has been tricky because it's hard to really know whether somebody has used the condom or not, because you are not there. So, and even reaching the youth with these condoms. So what we do, we create youth corners where the youth will come free and pick those condoms. And again, especially by the non-government organizations, they have tried to create HIV reproductive health and HIV integrated services targeting the youth. And they have tried to package the interventions in a way that the youth can friendly come and get the services. Thank you.
Great, thank you. All right, we have a question online in the chat box from Teddy. Wants to know about how high is the out-of-pocket expenditure on health in Uganda? That's a good question.
To give exact statistics, but as you realize, apparently we do not have a health insurance scheme. Though we have pockets started by non-government organizations. We have community-based schemes, but that is a very small percentage. So that shows that actually the biggest percentage is out of pocket. I might not be able to give the exact statistics. Thank you.
Well, as a follow-up from that, then, how about if we just go to so based on the health service delivery that you listed here, so I can, in a Canadian example, certain majority of public sector hospital-based things are covered by the Canada Health Act. So here in Canada, we would have a health card that we just use that to cover those types of expenses. Once we get outside of a traditional medicine model, we tend to pay more out of pocket here. So things under the traditionary and complementary medicine, they'd be covered under private health insurance or out of pocket. So would that be a similar system in Uganda, or in terms of what people are expected to pay for themselves?
I think it's quite different. Actually, my colleague Ekwaro is trying to provide some information here. Is saying Boniface, the National Health Account Study puts it at 40% contribution. So you see, it's quite high, and that's just an estimate. Okay.
Thank you. So Samantha has asked a very long question, so I'll read it out for those in the room. So Canada's medical system is largely, if not all, based on systems of Western medicine. However, you mentioned Uganda integrates both traditional methods as well as more modern Western methods of treatment. How does the healthcare system in Uganda find a way to harmonize and use both of these methods together? Great question.
She's called. Thank you, Samantha, for the question. Of course, the government of Uganda appreciated that you cannot easily do away with the traditional practices. People are so rooted in the culture. You still have pastors having a lot of influence on the community. You still have women delivering at home, being attended to by people who never went to school. You still have bone setters existing. So the government appreciated this and realized that it needs to work with the traditional practitioners. And therefore, it has facilitated some of these groups to form associations. And it is through these associations that they are provided with some training. They have incorporated some of these groups in our healthcare system. For example, the traditional bus attendants. I already informed you that they actually form part of the village health teams. So while village health teams are getting training on how to promote health, on how to distribute drugs, on how to generate demand for health services, the traditional bus attendants also receive that training. But also, in addition, they get more training on how to handle delivery. So in a way, they have tried to incorporate it, having realized that it's something that we are living with. Thank you.
So while we wait to see if another question comes up, I will mention from a forum scholar perspective. So one of our Queen Elizabeth scholars at the forum is Rhonda, who's just typing to us now, and she's going to be traveling to Ghana next week, and her project is actually dealing with women who are breast cancer survivors, and she's going to be looking at the connection and the integration within the Ghanaian system between traditional medicine and healers and more modern medicine. So that's what her project's about. So for those interested in that topic, stay tuned for sometime in the fall when Rhonda does her webinar, which will be based on that topic. So Rhonda asked the question, is there a healthcare system in East or in Africa that in your opinion would be a good model for Uganda to follow?
In my opinion, whereas all African countries have almost a similar setting, each country has a unique kind of setting. For example, you could see how we are able to coexist with the modern practices and the traditional practices. So I think each country should have a unique model that addresses problems in a unique context. Of course, I'm responding to Rhonda's question, where she's asking, is there a healthcare system in the East or in Africa that, in your opinion, would be a good model for Uganda to follow? I think the current model Uganda is following really is trying to address the real problems, which I think should be the best. Thank you.
Excellent. Thank you very much. Any other question? Oh, Equaro is jumping in, so.
Equaro Kwaro is trying to also add an answer to the question asked by Samantha. He's saying, Boniface, in addition, the government of Uganda, I think it is your question he's trying to answer, how the government has tried to integrate the traditional practices and the modern medicine. So he's saying, Boniface in Uganda put a traditional and complementary medicine act in 2015 to regulate the alternative medicine practices. Some like reflexology were banned. I hope you know reflexology. Yeah. Okay. Thank you, Kwaro.
So for those who are online, Aquaro is not a Queen Elizabeth Scholar. He's actually what we call a McMaster Health Forum Scholar, and he's also here visiting from Uganda, so he's giving Boniface a little bit of aid. So thank you, Aquaro, for that.
Another colleague of ours from Uganda, Dr. Robert Vasaza. Dr. Robert Vasaza worked with Minister of Health as a health planner, actually a senior health planner, is actually also adding that reflexology was banned, but the case was overturned in the Court of Appeal.
Are there any questions from anyone who's in the room with us here at the Health Forum? No? Oh, Joycelyn. So Joycelyn, who is one of our incoming scholars from Ghana, she'll be doing her presentation in the next few months. I will come over to her, and she has a question. Go ahead, Joycelyn.
Okay. My question is on the health system structure. Starts from the Ministry of Health and down to the very last. I was just wondering if a change in government actually affects policies or scholarship rolled out, and how you handle that, like in Uganda.
Thank you, Jocelyn. This is a system that is, of course, enacted in Parliament, and currently, I think the coups they are no longer more prevalent in Africa as they used to be in the Cold War era. So what happens in Uganda? We have peaceful elections. The president can retain his seat or loses it. So in circumstances when the existing government loses power, of course the system continues to run. So the system, this structure continues, because as much as we have elections at the top, at the presidency, we also have elections the different political administrative units. You know, this structure is somehow linked to the political administrative units. So we have elections at village level, we have elections at the parish level, we have elections at the sub-county level, we have elections at the district level. So you can see, even if we lost a president, and we get a new president, he selects a new minister, the public service remains. We have a permanent secretary seated at Minister of Health who does the technical work, and all his lieutenants. So that one remains. So nothing changes in the case of the change in government. Samantha, thank you so much. Probably I need to repeat your question to read some of the words James couldn't. Hi, Boniface. I had another quick question. I'll be traveling to a more rural area in Uganda, specifically in Kozi in September, as a QS from St. Mary's. I'm wondering how the health system typically works for visitors. You see, like in Canada, when you come, you need health insurance. In Uganda, like I mentioned, you might need to rely on out of pocket. So our health insurance is not there, so to say. So when you're a visitor, you have to rely on out of pocket. But also, it follows a referral system, which I think I should have mentioned, and thank you for reminding me. So cases are referred from Health Center 2 to Health Center 3, then from Health Center 3 to the district-based hospitals, then the district health hospitals refer to the regional referral hospitals, and if it's more complicated, then it is referred to the national referral hospitals. And even at the national referral hospital, there is a section of outpatients. So if you happen to be, I know Nkozi is a little bit close to Kampala, so you can move to Murago, there is an OPD, and get services. Thank you. She's asking me to choose between, you know, in Uganda, we have a say, there is a saying, in form of a question, that a chick and an egg, what came first? So she's asking me, what would you if you were to choose between these two building blocks, i.e. health workforce and health information, what would you advise to focus on first for purposes of strengthening the healthcare system? Now, when you look at all at the different building blocks, it's just like you are starting up, you want to build a house, and then you asking, do I need windows? Do I need bricks? Do I need the iron sheets? They are all needed. So, but when you are focusing, of course, the foundation is so important. So, and as we can see from evidence, you see health financing is so crucial in even having all these things done. So, and for that reason, in Africa, the heads of state thought wiser that they need to allocate more finances to the health system, which they are trying, though still below what they agreed. So I think you would do put in more resources, but also pay an equal attention to the other blocks. Thank you. Is online. Ekoro is in Uganda. I mean, he's from Uganda, but we are here at the same time. And whereas I'm going back on Monday, he's still here up to probably the end of June. He's saying to Samantha, thank you, Boniface, thank you. As an international, there are private health insurance schemes. Take some vaccine, e.g. yellow fever, hepatitis B, and prophylaxis for malaria. Use mosquito nets. Otherwise, internationals are welcome to provide care right from the community to the national referral hospital. Thank you, Ekwaro Obuku. Adds an answer to Samantha's question. Samantha, please contact your travel center at the hospital. Thank you, Vasaza.
So Joycelyn wants to know, for those online, what criteria is used when they decide to set up these health centers? Is it demographics? Is it health needs? Is it what is the case in terms of their decision making?
Thank you, Joycelyn. First of all, there is somebody who put a comment, I think, in reference to you, that I look forward to the presentation on Ghana. Yeah, what determines the setting up of these health facilities? Like I told you, they follow the political administrative units. And so the question is, how are these political administrative units created? They are created based on the demographics. So you are very right. So like I mentioned, at the bottom, we have villages. And each village probably covers 50 to 70 households. And that's about 250 to 1,000 persons. And so we have the village health team. A team will be managing at least 250 persons. So above the village, we have parishes. I'm sorry, I should have indicated those units here to make it more elaborate. So health center 2 is at a parish level. And then we are seeing a parish covers at least 10 villages. So you can have 250 times 10, that is 25,000. So it means one health center too covers like 25,000 people. No, I think 2,500, not 25,000. Then you have health center 3, which is at a sub-county level, and then which has at least 10 parishes. So if each parish has 10 villages, so you multiply again by 10. So it means each sub-county or each health center 3 offers services to 25,000 people. So demographics are key in determining the setup of these health facilities. Thank you. Yeah, Dr. Vasaza in Uganda is responding. Good response. Boniface, first administrative divisions, then population, and also resource availability. Okay. And of course, don't forget politics. And lobbying. It's all politics, yeah.
Can't avoid it, no matter what.
Can't avoid it.
Well, thank you very much. I think we can draw this to a close. I want to thank Boniface for taking the time to do his webinar. Again, he was our first webinar from the McMaster Health Forum Queen Elizabeth Scholarship Program, and it is the first in a series of webinars that we'll be conducting over the next 6 to 8 months as our scholars return. Our next webinar will be by Joycelyn, who's an incoming scholar from Ghana, and so stay tuned for when that will be booked. And then you can look forward to other webinars by our scholars who visited Australia and Trinidad and Tobago and India and Ghana as well. So thank you very much, everyone, and thank you, Boniface, and hope everybody has a wonderful day. Thank you.